In this scenario, a 42-year-old patient returns 3 days after an uncomplicated mandibular molar extraction complaining of persistent swelling. He has mild discomfort. His temperature is normal at 36.8 degrees centigrade. There is no trismus, no difficulty swelling, and the socket appears intact with a stable clot. The central question here is not how to treat infection. The real question is whether this represents normal postoperative inflammation or the early stages of spreading infection. This distinction is critical in ADC examination because the exam repeatedly tests escalation thresholds rather than procedural aggression. To approach this correctly, we must first understand normal postoperative pathology. After an extraction, the inflammatory response peaks within the first 48 hours. Swelling can still be present on the day 3 and may not fully subside until days 4 or 5. Mild discomfort is expected. The presence of swelling alone does not indicate infection. Inflammation is part of normal tissue repair. Infection implies bacterial spread beyond expected healing, and that requires additional systemic or progressive signs. The most important discriminator in this case is the absence of systemic involvement. There is no fever, no progressive trismus, no dysphagia, no airway compromise, and no worsening swelling. The socket is intact. These findings strongly support normal healing rather than spreading infection. In the ADC exam, when systemic red flags are absent, intervention is usually inappropriate. Many candidates fail because they react to swelling emotionally rather than analytically. If we examine the first question, which finding most strongly supports this being normal postoperative inflammation rather than infection, the correct reasoning centers on the absence of systemic signs. Pain and swelling are expected. Duration of 3 days is within the inflammatory window. What changes management is systemic compromise, and that is absent here. Therefore, reassurance with appropriate safety net advice is correct immediate management. Prescribing antibiotics in this situation is a classic trap. The ADC strongly tests antimicrobial stewardship principles. The antibiotics are not indicated for normal postoperative inflammation. They are reserved for cases showing spreading infection or systemic involvement. Overprescribing antibiotics reflects unsafe practice and defensive dentistry. Similarly, incision and drainage or hospital referral would represent overtreatment in the absence of escalation factors. However, this scenario does not stop at reassurance. It also tests whether the candidate knows what would convert this into a pathological situation. If the patient develops fever combined with increasing trismus, progressive swelling, dysphagia, or signs of systemic malaise, the threshold would shift. That constellation suggests deeper facial space involvement and would require escalation. The exam is assessing your ability to identify a tipping point, the moment when normal healing becomes abnormal. The underlying principle being assessed is the ability to distinguish expected post-operative healing from pathology. This is a judgment scale. Module 7 cases are specifically designed to evaluate whether you can recognize complications early without overreacting to normal physiology. The safe clinician does not treat fear. The safe clinician treats pathology. When faced with postoperative swelling in the ADC exam, pause and ask 4 questions. Is the swelling stable or worsening? Are systemic signs present? Is function deteriorating? Is airway compromised? If the answers are negative, monitoring and reassurance are appropriate. If red flags appear, escalation is required. The ability to apply this structured reasoning calmly is what separates high-scoring candidates from reactive ones. The final takeaway is simple but powerful. Swelling alone does not equal infection. Systemic involvement changes management. Module 7 is about recognizing deviation from normal healing and acting appropriately.